So there's a couple of other items, we have about 10 minutes, and I wanted to briefly get through these before we have our public give us some feedback. The first is that we have asked the Center for Evidence-Based Policy to do a systematic review on the effectiveness and harms on opioid tapers. They actually had a previous review which had partially looked at the questions that we're answering. This was published last year. We're asking them to update that and kind of specifically concentrate on some that are more specific questions. So in your packet, you had the PICO, the key questions that holds. And I don't know if you've had a chance to review those. I want
the page number.
Kat, do you know the page number?
If it's the public packet, it's page 69 and 92.
So what staff would like from you all, if you have any input into, these are the questions that staff came up with working with the med group, but obviously we want to know if these actually address what you want. So the PICO means population, intervention, comparators, and outcomes. The population we're asking for is adults who use opioids for 6 months or longer for non-cancer pain. The intervention would be an opioid taper or discontinuation of opioid treatment. The comparators would be no taper, different opioid discontinuation or tapering strategies, no comparison. So there are various things that we could have as comparators or have all. What we have asked to look for outcomes would be successful discontinuation, dose reduction, self-reported pain, quality of life, function, mortality. This would include accidental overdoses, suicide, any other causes of mortality, as well as adverse events like overdoses. So that's the PICO. Any input on that? Do you want to see any other interventions, any other outcomes as a population right? Yeah.
If it would at all possible to see if there are other systems or constructs that are adding not just to taper, but based off of the empowerment study, the Empower study, if you look at SUD in general, nobody goes into opioid treatment without a myriad of support. And I think that we might want to look at other supports in the tapering process. And
so what supports or what systems in place help predict successful
exactly,
tapering?
Yes.
Okay.
And that's built into key question 1E. So if we go through the key questions, we can highlight that. But under key question 1, which is what is the effectiveness for the effectiveness and harms of various strategies? And do they vary by and tapering supports? And it says e.g. behavioral interventions or additional therapeutic modalities. So we thought that was really critical because obviously that would be a key strategy within this intervention.
Okay, so I'm not hearing any questions about the policy, the population, any other comparators that you all want or outcomes? Okay.
This is a question for the pharmacists, maybe or physicians. Would it be useful to look at whether the patient was then also put onto another medication versus taper, which is just taper?
It's like Suboxone or
non-opioid.
We can specify that in other supports, that would be one of them.
Yeah, that's on that.
Medication?
Yeah.
Okay.
So under the outcome measures, I just assume that everything on that list is self-reported with the exception of the last two bullet points, not just self-reported pain, but self-reported quality of life, self-reported function. Am I correct about that? Those would be surveys?
Yes, they would be validated tools that
Right.
would measure, but it would be patient responses to those validated tools.
Good, thanks.
I have another one. Is it possible to also call out among therapeutic modalities, to Dr. Piccaro's point, whether the patient received pain education, what their understanding is of pain?
So patient education as
So
one
additional
modality.
therapeutic modalities, including pain education.
we can
Just call
suggest
call
that.
that out.
So it sounds like you all want called out pain education, other medication supports, and then any other systems in place. Any other feedback on the PICOs?
So I just want to highlight that the question 1D is whether tapering or discontinuation is voluntary, i.e. patient decision, or involuntary, i.e. the decision of someone other than the patient. And so really understanding where the literature is on this particular question is critical.
Yeah, so moving on to the key question, thanks Kat. So basically what we're asking is what's the evidence of effectiveness and harms of various strategies for tapering or discontinuing opioids among patients with chronic non-cancer pain, and do the effectiveness or harm of these strategies vary by the medication type or dosage, the morphine milligram equivalents, population characteristics, whether the tapering or discontinuation was a patient decision or a decision by the health system, the provider, or other outside actors. What supports were given, and we can add in the other ones that you specified about patient education and other supports, and then speed of the tapering were the ones. Anything in that key question that you all feel should be changed or added to or clarified?
So in a previous meeting, we talked a little bit about different diagnoses, and our original work in this committee was not to talk about opioids for rheumatoid arthritis or a number of conditions that are already covered benefits on the Oregon Health Plan. And one of the difficulties we ran into is that by and large the literature doesn't tease out very well by diagnosis. Should we ask them to see if there's any update on that, or is that immaterial to the discussion?
So I think that's critical to the discussion. So we tried to go right into the key question 1C, where we talk about the population characteristics, where diagnosis is one of them. So yeah, I think that's a critical point.
One other thing, and I don't know if it would be appropriate or germane, but do we want to see, prior to tapering, what other medications people are on, to see what effect that might be having? Is that on there?
It was medication type.
Yeah, it's not specifically called out. We could add that to the population characteristics and say concurrent medication use right after comorbidity, perhaps.
I think that co-prescription of benzodiazepine may be an important thing to add in a population characteristic, because in my clinical experience that does make tapering more challenging, and I think that the population characteristics of folks that are co-prescribed benzodiazepine and opioids might be different.
And the other population that rises to my mind is those using marijuana. Across parts of Oregon, there was a significant initiative to restrict those using both marijuana and opioids for chronic pain, where people, for example, had to choose between one or the other. And so if we have any evidence on how this differentially impacts, and that's something that would be useful to look at as well.
Although I suspect, given the dearth of literature in marijuana in general, it might be difficult to tease out.
But I think that drove a lot of opioid discontinuation, and certainly did in my clinical practice.
Just to clarify, what you're saying, is to clarify those people who were asked to make a choice and therefore tapered because they wanted to continue with cannabinoids instead of opioids. Is that?
I mean, if that exists. So again, we're looking at what's been studied, and so if that's never been studied, we're not going to have any information on it. But I knew that was a significant community effort that happened across a lot of community centers in Oregon, and so understanding if any type of study has existed that looks at that kind of intervention, that would be valuable. But we may not have any evidence.
And the reason I'm asking for the clarification is because another question exists about the degree to which there is harm to patients who use cannabinoids and take opioids, if I understand correctly. There's a lot of discussion in this state, and yet I don't know that there's a lot of actual accurate information.
Right, so I would just propose that if that evidence is findable, that we look at it.
So I'm happy to forward you the evidence around cannabinoids if that would be helpful, but basically it's a slew of cross-sectional studies, one prospective study that's very exciting, but it's not controlled, and then one RCT that's underway right now.
So there isn't going to be evidence on it.
Well, not at that top of the pyramid, not that evidence.
So I think what's also important for everyone to know is that there is going to be very direct evidence as to what exactly this type of policy does. Because for the vaccine policy, which was implemented by the HERC July 1 of 2016, there are now 2 nationally funded studies that are looking at the impact of this policy that we are now 2 years into. And so, well, hopefully people heard the first part of it because it's kind of important. But the net result is we are going to have directly applicable evidence of the impacts of the policy that HERC made 2 years ago that shows what happens when you make this policy lever decision and what happens to the population over time. So we will have this data in the near future.
There's one other study, not as directly relatable, but Dr. Krebs, who did the space study, she, part of the study was that anyone who was on the opioids was mandated to taper off their opioids at the end, and they've been studying that population. And so she just, personal communication with her, they're going to publish that. However soon it goes through all the literature, whatever. But just as a personal communication from her, they had no poor outcomes from that, but it was a controlled environment with a controlled population. And that's personal communication, it's unpublished.
I don't know if this exists anywhere, but in our clinical programming, we find that people that are tapering either voluntarily or not, if their home life situation is such that it doesn't support that process, the likelihood of that being a successful taper is negligible at best. And I'm wondering if we could tease out pre and post, do we have other people either using prescribed opioids or using non-prescribed opioids in the living situation of that person? What's the effect on outcome?
I think we can ask for some population, like some of their background information, but I don't think it's going to be possible to really tease out the details of their living situation. It would just be more gross, like income level perhaps, or disability level, or education, which may or may not relate to that question.
So I have a request for the audience who may not be used to hearing about discussions about the development of studies like this. If you could just reiterate what the hoped outcome will be in non-jargony language of this work.
So what we are hoping is to find the best evidence out there of what happens when patients are tapered off, what their outcomes are, and then if there are information that we can find about best supports or best ways or et cetera.
From existing studies.
It would all be from existing studies. Now, I just want to be a timekeeper. We had told the public that they would be able to have testimony starting about 5 minutes ago. We have one other item, which is we're going to be surveying the CCOs about specific details. I want to ask you all about that. But I want to be cognizant of our agenda. So I'm going to switch this over to